Toric oil for beginners. I invite the panel members, Dr. Vijayalakshmi, myself, Dr. Nisha, Dr. Sugandha, and Dr. Jashina. Dr. Sugandha is a very good phacosurgeon, doing torics more frequently. I invite her for the talk on for whom you will select, for whom, which patient you want to put a toric oil. The details will be follows.
So good afternoon, everyone. Today, our instruction course is aimed at all the phacosurgeons who are transitioning from monofocal IOLs onto toric IOLs. And this also would be very beneficial to all the phacosurgeons who are looking to optimize their toric IOL outcomes. So let's begin with patient selection guidelines. So of course, an ideal candidate would be a patient with visually significant cataract along with astigmatism. It should be a regular, symmetric astigmatism. Always aim low, that is, beginner surgeons should always aim for correcting a corneal astigmatism between 1 diopter to 3 diopters. And always aim to have a patient who has a good ocular surface, a regular cornea on topo. That is indicated by very crisp Placido rings. And of course, a healthy tear film and a good Schirmer value. Of course, you should have a normal optic disc status and macular status to have a happy patient at the end of your surgery. And the last point that I need to emphasize over here is the patient's need to be spectacle-free for distance or near viewing or both. So you must always optimize your surgery in such a way that you are addressing the patient's need for astigmatism correction. If the patient's requirement is a good uncorrected distance vision, whether or not the patient has astigmatism will determine whether you want to implant a monofocal IOL or a toric IOL in this case. Of course, you can also go for a multifocal toric IOL if the patient is affording, which in our scenario, a lot of patients are coming forward who are looking to optimize their distance and near vision both, be completely spectacle free. And all the phacosurgeons who are just moving on or transitioning from monofocals to toric, I would suggest that you better avoid, at least in the beginning few, say about 50 cases, until you get your hands steady, to avoid these particular conditions. These are not contraindications per se, but then you would be better off avoiding these situations like extreme degrees of zonal instability, say in case of pseudoexfoliation, say there's a history of trauma. Of course, history taking is very important in these cases. If there's an irregular astigmatism, a dense corneal scar, or progressive pterygia, or an ectatic cornea, a pre-existing PC dehiscence, PPC per se is not a contraindication. If you can get a good round central posterior capsule, which you can turn it into a PCC, go ahead and implant a toric IOL. I'm just saying that the beginners should avoid, in the first few cases, better to stay off these cases. Then advanced glaucoma, definitely, how much ever you do a good cataract surgery is not going to affect the visual outcome because of the optic disc abnormalities, like, say, if it is an advanced glaucoma, suboptimal macular health or macular degeneration because of various causes, age-related or myopic, etc. Prior VR surgeries, again, no contraindication as such, but beginners better to avoid. Prior refractive surgeries like PKP, RK, the end results or the outcomes are variable. That is why beginner surgeons, to get your feet, get your confidence, first few cases, better to avoid these cases. Previous history of scleral buckling, glaucoma infiltration, glaucoma implants and filtration devices. Also exercise caution in hypermature Morganian cataracts with sclerotic capsules, only because there can be issues with a well-centered rhexis. If you can have a standby monofocal IOL, it'll be good. In case you get a good well-centered rhexis, go ahead and implant your toric IOL and the patient will always thank you for it. Poor pupillary dilatation cases, if you are confident with placing iris hooks or rings, please go ahead and implant your toric IOLs. But in case you're not confident, better stay away from poor pupillary dilatation cases because you will not be able to visualize the markings, the dots or lines that are there to denote the axis. PCR on table, again, is a contraindication because your if you put a sulcus implanted IOL, it always has a tendency to rotate, and I'm not aware of any 3-piece IOLs which have, which can correct toricities. Amblyopia. Now we had a case who, of course, the patient was very well counseled pre-op, but then the patient ultimately turned out to be a little unhappy in the end, even though we had counseled pre-op that, because of the difference in the axial length, there was some amount of, it was a young patient and he was not happy post-op. So in the beginning, to get your confidence, please stay away from cases who have identified amblyopia. So history taking again is very important. So address potentially treatable issues like a dry eye, low Schirmer and T-butt values, meibomian gland dysfunction, pterygium, contact lens wearers. So this is a case of extreme dry eye. If you can see the corneal topography, it would look like an ectatic cornea. You can see the KISA value as 379%. But when I checked the Schirmer's value, it was very low, and T-butt was quite low. In the left, this is a topo of the left eye, so you can see the T-butt is at just 8 seconds. The same patient, after 2 weeks of topical lubricants, the cornea topo looks perfectly all right. Now this, I'll just take a couple of minutes more. Pterygium causes flattening of cornea in the same axis, so any small atrophic pterygia may not cause any significant astigmatism, but vascular fleshy pterygia, which are obscuring the visual axis, should be addressed first. And toric IOL can be planned 6 to 8 weeks later. Surgeon factors. Now, technically, toric IOL surgery is no harder than a non-toric IOL surgery. Like I suggested earlier, better to avoid certain conditions just until you find your feet into the surgical practice of toric IOL implantation. Beginner tips, of course, adequate pre-op counseling. Always take both eye measurements. Refractive status of both the eyes have to be taken into account to avoid refractive surprises like amblyopic cases and unhappy patient in the end. Understand patient expectations and requirements and match the IOL to the patient's job, hobbies, etc. Use of brochures and color topo that you can make the patient understand what you are aiming at, and select an optimal eye and the patient. Plan your surgical schedule, especially for beginner surgeons. Better to choose cases with regular astigmatism with a symmetric bow tie pattern. So biometry tips, ensure correct head alignment. Optical biometry and manual keratometry are always preferred methods. And always, if any inconsistency or varying values, always cross-check with topography and manual autokeratometry. SIA, or 2.2 to 2.4 millimeter incision, always ensures no to minimal surgically induced astigmatism, and all cataract surgeons should be aware of their SIA. So these are just to show you a young patient with WTR astigmatism and an older patient with a ATR astigmatism. Take-home pointers: aim small, miss small. So beginner surgeons start by correcting between 1 diopter to 3 diopters of astigmatism. Start with straightforward cases, a good eye, good corneal surface, good retina status, and always educate the patient about the refractive outcome and the rare possibility of re-rotation. We've had such a case, I've had such a case of rotation, which was a nightmare for me. Okay, and so realistic patient expectations, good surgical planning will lead to a good surgical outcome. Thank you.
Thank you, Dr. Sugandha, for the wonderful presentation.